I'm Connie Horgan. I'm a professor at the Heller School at Brandeis University and director of its Institute for Behavioral Health and co-director of the Schneider Institutes for Health Policy and Research. I am joined today by my colleague, Sharon Reif, also a professor at the Heller School at Brandeis and the deputy director of the Institute for Behavioral Health. I was trained as a health services researcher and was focused squarely on the healthcare system. Early in my career, I became intrigued as to why so little was being done in the behavioral health area compared to the broader healthcare system. It became my professional passion to use health services research to improve the delivery and quality of alcohol, drug, and mental health services. Given the prevalence of alcohol problems in our society, it seems strange to me that we weren't using the tools of health services research to improve the delivery system to a greater degree. I am appreciative of the funding that NIAAA has devoted to the goal of using health services research to improve the system. First, I'd like to give a little overview of our presentation today. First, a little overview of what actually is health services research. Next, how is the health system changing? I think we all will agree that it has changed a lot in the past year and a half during these pandemic times when we think about getting any health care, whether it's for alcohol treatment or for anything, just looking at the switch to telehealth, things like that. This is what health services research is all about. It's the delivery system and how services are provided. Next, I'll be going on to the key issues for alcohol services. Then we'll be switching to my colleague, Dr. Reif, who will then speak about typical data sources and methods that are used in health services research. And we are going to be speaking about 3 examples that play up and show what these key issues are. Dr. Reif will first be giving the example of supporting recovery through recovery coaching, and then we'll switch back to me and I will be talking about paying for things and how you organize things, integrating into a system. And we will end with looking into the future. So what is health services research? It is translational science. It fits right in. We are the last stage of translational science. We take what's been learned in the lab, in clinical research, and incorporate it into the real world delivery system. When you think of health services research, think about the real world and how to study things in the real world, not in a lab, not in a clinical setting that is controlled. Health services research examines 4 basic questions. How do people get access to healthcare? Is the service that they get of high quality? How much does it cost? We keep hearing about runaway healthcare costs. Cost is an issue for the delivery of alcohol services as well. And most importantly, what is the outcome as a result of the care? The goal of health services research is to support the delivery of high quality care based on evidence. We study the most effective ways to organize, manage, and finance service delivery. I thought it would be useful to look at this classic conceptual framework of health systems. Traditionally, the health system has been thought of as the relationship among 3 players. You can look at this slide and see the 3 corners of the triangle. First, the payer, which of course is the insurance system, Medicare or Medicaid on the private side. Second is the clinician, the bottom of the triangle, the provider of the service. And thirdly, and most importantly, the patient. It's a relationship among these players. But there now are more players in the system because the provider organization now becomes between the payer and the clinician. And health services research is all about the relationship among the players. I will give a couple of examples to make this a little clearer. For example, the relationship between the payer and the patient. Simple question, is the medication that you would like to be taking on the formulary. So is it paid for? For example, is naltrexone on your formulary? The relationship between the clinician and the patient. Is the clinician using evidence-based practices? The relationship between the payer and the provider organization. Are they being paid on a fee-for-service basis, a unit basis, or are they using some other method? This is what the system looks like in terms of how the players relate to each other. And it's all looking at how can we attain a system, linking back to the previous slide of access, quality, cost, and outcomes. The next slide shows us that in alcohol services research, we look across the continuum of care. It's not just treatment for a certain number of days. It's across the whole continuum. It's the prevention and education, prevention services research. It's to raise awareness. It's the recognition of the problem and identification of the problem in the first place. And then there's treatment associated with rehabilitation of substance use disorders. And finally, and sometimes it's given short shrift, maintenance. What activities relate to sustaining long-term positive outcomes and supporting recovery? Health services research is about the entire continuum. How is the system changing? Bet you didn't think you'd be looking at pictures of Mustangs in this talk, but I'd like to use this as an analogy. Many would say that we've been through profound change in the last 50 years. I'll point out that NIAAA just had its 50th birthday, so we can think back to what it was like when NIAAA started. But I like to compare it to these cars. Externally, these cars, I would say, look remarkably similar. They have 4 wheels and a chassis, and they get you from one place to the other. So in that sense, there really hasn't been much change. But when you look under the hood, are they different? Are they an electric car? Are they using GPS? I would argue, for one, that in 2020, there's a lot that's different in those cars that are new and improved. I'd like you to think of this analogy and apply it to healthcare as we think about some of the foundational changes that are taking place in the alcohol prevention and treatment systems. This is just really a listing of some of the really key imperatives that are happening in healthcare. And these are the things that health services research is looking at, and where the 3 examples that we will be giving later fall into place. Healthcare reform and parity, major forces. It makes a difference whether people are covered. And there's been coverage expansion. What does that mean? There are new delivery models for alternative payment. There's a new, it's not new, it's actually been for the past 10 to 20 years, but the substance use disorder field is later to become a player in measuring and rewarding performance and using incentives for achieving accountability and quality improvement. Information technology is rampant, and there's greater use of electronic health records and automated databases. What difference is this making? And there's a movement towards integrated care. There's no wrong door. How are we doing in that area? And is it truly no wrong door? And there have been many innovative interventions. We've seen telehealth burgeon in the last year. Recovery coaches are much more common, and there's greater use of medications for treatment. This is just a little slide that is specific to alcohol. In the first column, we have description of the past. On the right, we have now and in the future, how things have changed. I can't take the time to go through all 10 on this list right now, so I'll pick out a couple. In the past, treatment was in specialty sector. It was mainly ignored in primary care. Now there is much more use of screening and monitoring in primary care, and a greater use of the mainstream medical sector for the delivery of treatment. Looking down to, let's pick number 3. It used to be paper charts, little contact between the specialty system and the specialty substance use delivery system, alcohol and drugs, and the health system. But now we have electronic health records that are being used to enhance clinical coordination. Let's look at number 7, medications. Medications were seldom available for treatment of alcohol use disorders, except for antabuse. Now we've moved to the state where medications are covered by insurers, and the payment for medications is far less of a problem than it used to be. I'm not saying medications are being used. I'm saying that many health plans now cover these medications. These are just some of the ways that things have changed. So that practically everything you could look at in the past and say, what is being done now and what does the future hold to improve the delivery of treatment? NIAAA has been dealing, as I mentioned in my introduction, with health services research. And some of these key issues are what NIAAA in the next slide has been focused on. This is a statement from the last strategic plan. I know we'll be coming out with a new strategic plan soon, but this is from the current strategic plan. And one of the objectives of NIAAA is to focus on the evaluation of the effectiveness, accessibility, affordability, and appeal for alcohol use disorder treatments and recovery models. And not just to evaluate, to test the strategies in order to increase their adoption in real world settings. This real world terminology is something that you will hear a lot in health services research. I'd like to just mention a recent RFA from NIAAA that was aimed to support the development and evaluation of strategies to support services research. It had a focus on disparities, and it focused on how can we reduce the barriers that prevent people from seeking and receiving appropriate care. Are there alternative ways of getting into the treatment system, reaching out to people to get them in, identified and into receiving treatment? How can we enhance the dissemination and implementation and adoption of evidence-based practices across the spectrum of services? Number one, we have to train people and we have to pay to see that these services are paid for. And how can we develop models to treat alcohol treatment and recovery in all settings, the non-medical settings and medical non-specialty settings? By that is primary care, but it also can be specialty sectors such as in general medicine for treatment of liver disorders, things of that nature. It's treating the whole person where they come into the system, whether it be in primary care, specialty medical, or it could be even the specialty system. And how do we look at treating the person in an ongoing, comprehensive way, in looking at conditions for some people being chronic and treating their other alcohol-related conditions in the healthcare system. The next slide shows some hot topics in health services research. I'll just point out a couple before moving on. Medications for alcohol treatment. There are medications that are out there. There's been a lot of focus on medications used for opioid treatment. There's been far less a focus on this in terms of getting these medications used in the real world. We're looking at integration of alcohol into mainstream medical treatment. That will be one of our examples that we'll be talking about later on. Services for vulnerable populations provided in a culturally appropriate way. A couple of others. What is the role of individuals who help clients navigate the treatment system? The role of recovery coaches. We all know that there are social determinants of health. What is the role of these in achieving sustained recovery? Housing, for example. The issues of racial equity and approaches to alcohol treatment are so critically important. And though the research shows that disparities in entering treatment are different depending on racial, ethnic differences. The workforce is important, both in being a place that is recovery friendly, number one, if you're a worker there, and then how do we expand the addiction workforce because there is a shortage of workers in the treatment system. How do we better access recovery to support services? Frequently, the system sort of ends with treatment, and we need to support recovery more. And finally, one of my favorite topics is the payment. You get what you pay for, so value-based payment is something that is really key. I would like to now take a break and turn the presentation over to Dr. Reif, who will be talking about typical data sources and methods.
Great, thank you. Like any research, health services research uses a range of data and methods to address pressing questions. However, since health services research is system-based and, as Dr. Horgan just mentioned, based in the real world, it considers myriad ways to improve the delivery of high-quality care to individuals, and we consider multiple levels to be relevant. For healthcare delivery, we go beyond the individual person to consider who interacts with them, that is the workforce, the organizations in which they receive their care, such as hospitals or substance use treatment programs, where they receive other services such as housing, or with which they otherwise interact, such as the criminal legal system or schools. The communities in which they live, work, and receive care, and their own cultural experiences that include the effects of racism and stigma, and the societal level norms and policies under which we all live. Ideally, health services research data sources and methods consider these many layers. Primary data sources for health services research frequently include surveys, interviews, and focus groups. Household surveys provide population-level information, such as the National Survey on Drug Use and Health, or state-level behavioral health risk factor surveys. Surveys could also be done at the systems level, such as surveys of health plans or hospitals, and interviews or focus groups are particularly important to capture individual perspectives, such as those of clinicians, policymakers, or people with alcohol problems. Health services research also makes extensive use of existing data. Insurance claims, administrative data, and medical records provide evidence of services received, of billing, and similar information. Summary data includes systematic reviews, meta-analyses, and policy analyses, which enable a higher level view of implementation. How do these things work in practice? And effectiveness, what are the outcomes, again, in the real world? More recent data sources include public health surveillance, such as for overdose deaths, and data from apps or digital tools. Methods for health services research are also wide-ranging. With existing data, we typically use quasi-experimental designs, building comparison groups from within the data, for example, or naturalistic experiments when interventions or policies are rolled out at different rates or within a subset of organizations. These may use traditional multivariate methods, they may use multi-level methods, and trend analyses, interrupted time series are ways to evaluate such policies. Implementation methodologies are as important as effectiveness studies. It's one thing to know if something works, it's another thing to know how it was put into place and how that matters for whether it works or not. To move towards quality, performance metrics are key, as you will hear in later examples, and they need development, testing, and evaluation. And economic analyses are essential to inform the real-world uptake of potential interventions. Several examples should help our understanding of health services research related to alcohol use disorders. First, for many people with alcohol use disorders and other substance use disorders, recovery is the ultimate goal for the work that we do, the interventions that we have. To achieve recovery from alcohol use disorders, many people benefit from recovery support services such as recovery coaching. When we consider recovery, the social determinants of health can play a major role. These can include employment, housing stability, access to care, and health literacy, for example. Recovery from alcohol use disorders can be threatened or not attained when such needs are unmet. Yet these are also needs that traditional healthcare settings are generally less skilled at addressing. Recovery support services focus on a broad range of basic needs, social supports, and well-being that are essential for attaining recovery. There are many types of recovery support services, ranging from mutual help to recovery housing, to digital apps, to shared decision-making processes. Peer recovery coaches in particular have lived experience of recovery from substance use disorders themselves, And through that, and with other training often, they can offer support, modeling, hope, and just general guidance for people who are moving towards recovery, be it in the short-term recovery or longer-term recovery. And particularly, they can complement the services that are traditionally provided in healthcare and especially substance use settings. Recovery capital is a framework for considering areas that may need development among people who have substance use disorders and helping them to succeed in recovery. For instance, social capital focuses on the benefits of social supports and perhaps rebuilding those relationships. Physical capital is often known as economic or financial assets that allow options for pursuing recovery. Human capital is about the knowledge and skills that you have to negotiate daily life. And cultural capital builds on the values and beliefs from membership in a cultural group and constructs that will help support recovery. It's not to say that anybody who is in recovery or seeking recovery is missing all of these aspects or any of these aspects, but they are what strengthen and build resilience for people. And this is where recovery coaches can come in with their own lived experience to help move people towards these needs that are beneficial. Recovery is still a nascent area in health services research. There are certainly studies that are happening in this area, but many, many questions remain about the use of recovery coaches in this example in systems of care. What are effective models for integrating recovery coaches into healthcare settings? It's been done, it's in practice. How do we know what those models are that are useful? Are there barriers to implementation in healthcare settings or other settings for recovery coaches, particularly in mainstream medical care? You will hear another example in a moment about integrating care. Recovery coaches will fall into that as well. Are there facilitators? Are there ways that they work better within these systems? How are recovery coaches paid for and by whom? Is there billing under insurance? Are there other ways that needs to happen? Does certification of peer specialists as recovery coaches improve the quality of services received? Can performance measures be developed to ensure high quality recovery coaching? And what are appropriate patient-centered outcomes that address the range of complex needs and support recovery? And how do all of those prior questions feed into the outcomes that we want to be driving? In summary, recovery support services are an important component to support people with alcohol and drug use disorders. They are effective in producing recovery outcomes, including improved relationships with providers and social supports, reduced rates of return to substance use, increased treatment retention, and increased satisfaction with overall treatment. So with that, I'm going to move back to Dr. Horgan for our second example.
Well, as I mentioned earlier, how one pays for things frequently drives how care is provided. So that's what this example is going to focus on. I'd like to start out next with providing a historical context from the Institute of Medicine studies. It's been 20 years since a very famous report came out from the Institute of Medicine, and it was called Crossing the Quality Chasm. It was applied to all of healthcare, not just behavioral health, but it was calling attention to the fact that there was a growing chasm between the actual delivery of the services and the quality of care that we need. We were spending a lot of money, but the quality of services was not what it should be. Many studies that were done. At that time, there was a very well-known study done by the RAND Corporation that looked at 25 common medical conditions. One of the 25 was treatment for alcohol. And of the 25 services that were looked at, the alcohol came in 25th in terms of the quality of services. This was based on going back and getting chart reviews and things like that. So there was a chasm in all of healthcare, but it was particularly acute in behavioral health. Then there was another well-known study from the Institute of Medicine that focused on the issue, we'll call it value-based purchasing. Some people called it pay for performance. And this was back in 2007. but it was encouraging the deliberate use of payment incentives to reward quality, and that these incentives could serve as a powerful stimulus to drive institutional and provider behavior towards better quality. So the rest of this example is really about merging these two issues, using payment to improve quality. The next slide provides just a little bit of context on why this is the case. Historically, healthcare offered few financial rewards. You got the same amount of money regardless of the quality or outcome. High and low quality providers seem to get the same payment at the same volume levels. This is not the case in other markets. Just to use an example from the hotel industry, hotels are not the same price. You expect that if you stay at the Ritz-Carlton, you might be getting a different level of service than staying at Motel 6. So there is a difference between payment and quality. What value-based purchasing does is to offer financial incentives to improve the issues of quality care, access, and efficiency. It's using the payment system, how providers are paid, or how the organizations in which they operate are paid. How do we design effective value-based purchasing programs? There are two issues. One is, what are you going to measure to show that you are making improvements? And how are you going to pay for it? There's a whole science out there on how do you choose the measure of what you want to incent. And the other is, how do you pay for it? Are you going to pay on a fee-for-service basis by the unit, or are there some alternative ways of paying for it or incentivizing the provider that if you're paid for outcomes, that it will improve quality? So that's a very basic description of these two concepts of putting measurement together with payment. The next slide shows 4 very commonly used now addiction performance measures. I will say the addiction field has been behind the health field in terms of developing measures of performance, but there has been a lot of work in very recent years, and there are commonly used performance measures now on screening and brief intervention across a population group, how much screening is going on of those who screen positive, how much brief intervention takes place, and you measuring how well this is happening. Identification of how well is a health system or a provider identifying alcohol and drug use disorders. What do the numbers show, measuring it? After identification, there's initiation. Of those identified, how many actually get into treatment? And if they initiate treatment, do they engage in treatment in longer term? These are some very brief, simplistic measures, but they're very commonly used in health plans, both public and private, in payment today in these measures. So the addiction field is moving into this area. The other aspect that I'd like to bring in is, how do you move to value-based payment? I gave the example of before, I gave the hotel industry, the fee for service, that you just pay for a given unit of service, and it didn't matter what you got, that you got the same payment. There is a movement now for organizations to be paid for their performance, for the scores they get on these performance measures, some of which I've described. They can be incentivized for it. Frequently, what we see is individual services are not paid for just by the unit. You might see services bundled together. There could be a bundle payment that includes several types of services that were given for a given outpatient episode, for example. So there is increasing use of bundles. One commonly used bundle is linking payment for medications with the visit and bundling them together. So in theory, if things are bundled together, it gives the provider more flexibility as to what they want to provide in the payment. And the most aggregated payment is the global payment, or analogous to capitation, where you're paying for all of the services under one fee. The next slide talks about the concerns with value-based payment. And there are many. There's research on all of these areas that are listed here, research on developing the payment structure. When you talk about incentives, what do you want to pay for? If you are in a system where you want to have everyone improve, you would pay for improvement, that if you go up a certain amount in your score, that would be paid for. And another system may decide that they would just like to have providers attain a certain level. So there are differences in how you can go about payment. Probably the most important thing is how much you're paying. Having a fancy model for payment and still having the amount be very small is not really going to be very effective. Whether you're going to reward someone for high performance or whether you're going to have a penalty for poor performance is a decision that needs to be made. There are issues of gaming. If there's incentives involved, sometimes people try to find ways that they will get a higher score. So there have been instances of what's called creaming, where a provider may try to have more of a certain kind of patient come in because they do better. There have been studies where there was preferences for people with certain kinds of insurance because they tended to do better. One big concern with using performance measures is actually playing to the test. If you provide an incentive for certain types of things, let's say screening and identification, but are not incenting some other part of the continuum, will providers put too much emphasis on what you're providing the incentive for? There's a concern about other unintended consequences, particularly the issue of increased disparities. So value-based purchasing comes with a lot of concerns. However, it is the modus operandi right now in many payment systems. Medicaid programs are widely using it, Medicare is widely using it, and many insurance plans are using it. So providers are being paid under value-based purchasing right now. The next slide gives a summary of this newer phenomenon. They are well established in the medical arena. Much of Medicare is paid for under value-based purchasing arrangements. It is less well developed in addiction and mental health services. I will say the rigorous studies are few, but they are emerging. Thus far, the evidence is mixed. There are some results that say that it doesn't have any impact. Other studies have shown some modest improvements. Nothing that there's a magic bullet here, but there is some modest improvement. The one thing to be very concerned about is to always be alert to the unintended consequences. Is it disproportionately impacting a certain population group? The issue of disparities comes in here. So I guess the conclusion here is we are still very much in the early learning stage of how to use value-based purchasing effectively. It shows considerable promise, particularly in the medical arena, but it still has formidable challenges. I'm moving on to our third example. The second example was payment. This third example is how we organize the delivery system. We're looking at encouraging integration of services. It's doing more of a deep dive on the question of having services more coordinated and integrated. Does this lead to better quality and outcomes? This slide shows that in the past, there has really been a very siloed approach to behavioral health and physical health. And behavioral health would include both mental health, alcohol, and drug treatment. Currently, there is a lot of talk about integrated services, integration of behavioral and physical health. There are all kinds of demonstrations and models that have come out to better integrate services. And I would say that we're still in the testing stage. It's moving in a more integrated manner, but we are not at the future yet where we have a very warm relationship between behavioral health and physical health. It varies a lot depending on the healthcare system. This slide looks at integration sort of in a big picture issue, because integration is about where you receive care. And actually, alcohol services can be provided in all four of these sectors: primary care, specialty substance use and mental health services, specialty medical services, and then the recovery support services. Where do they take place? So when you think of an individual, sometimes they may just get all of their care in one setting, but typically there is movement back and forth between the sectors. For example, someone might be screened in primary care, determine that they would be best referred to a specialty treatment setting, and then needs to move on to recovery support, which could be provided in primary care or one of the other settings. It depends on the model of integration and how it's set up. Increasingly, there's interest in specialty medical setting being used to a greater extent to treat behavioral health conditions, because many people are in certain specialty areas because of problems that relate to their abuse of substances. So integration is looking at all of the settings. And again, the issue is somebody may move between settings. It's not that you're permanently getting your care in just one setting. The next slide tries to give a framework for looking at integration, because it's complicated. When you think of provision of care, you think, aha, the clinical part of integration is certainly key. But part of the framework of delivering this care across these settings is the issue of having an infrastructure that supports the integration. This is the structural part of it. Does the technology, the practice redesign, the training exist, the technology exist to support the integration? How does it intersect with the clinical and behavioral health needs of the patient? And then the financial issue is it has to relate to financing, and payment policies have to support the structural and clinical integration. So it's all these cogs working together that can create integration. You can't just look at integration as a clinical issue. You can't just look at it as we'll pay for it and it will happen. You have to have all three together to provide a supportive environment for evidence-based practices and incorporating them into care. I'm trying to bring this down to the level of how payment can help or hinder the coordination, the integration of care. Some examples of things that some people would say would enhance integration, but does the payment system pay for the coordination activities that are needed? The outside face-to-face visits, for example. We've seen in the past year that yes, with mandates that go out that telehealth will be paid for at the same basis, yes, this did happen and may continue after the pandemic is over. But paying for the types of activities are key. Do PCPs get rewarded for identifying or referring patients with addiction problems? How does the billing support coordinated care? Is it difficult to have your billing support the payment? And that's why there's such an argument for alternative payment that would cover it all in a bigger basis. How can payments support a coordination? Team-based care is the mantra for integrated care. Is it paid for, or is it still on an individual provider basis? Can payments support the investment in infrastructure of the computer systems that are needed, the technology that's needed for coordination? And does payment support both the front end, the prevention, and the back end, the chronic disease management concepts that we've talked about on the continuum of care framework? Does integration work? Clinical integration has been shown to improve treatment outcomes for many behavioral health conditions, for reduced drinks per drinking day, for abstinence. There's been some evidence for that. Most patients report improved patient experiences with clinical integration, and it has been shown to reduce costs and service utilization for populations. However, again, as in the payment area, there's not clear evidence yet about which care processes, which models of integration, and which payment structures are most effective. So I would say that we are very much in the early stage of research in refining what will work in integration and how to pay for it and how to organize it. But in summary, for integrated care, there are opportunities currently in the system for integration. It is happening in some systems. Evidence shows that integration can improve care, but the underlying issue for integrated care is based on the principle that there is no wrong door for consumers. They can come in through any setting or means. I've just given two examples. The first focused on payment, the second focused on how the organization and the delivery system. And this slide summarizes why we should care. What difference is it going to make to actually address the systemic barriers in care so that we can improve the delivery of care? It can be argued that it does reduce stigma depending on what setting someone is in. It addresses the technical issues of needed training and support. It looks at the issue of carrots or incentives to encourage change. Paying for integrated care and other types of services reduces the silos of things just being non-permeable and not relating to each other. And reducing the regulatory and financial barriers addresses some of the pitfalls with sustainability, and that the service will continue on past just being a demonstration. So looking to the future, the key issues we would argue for alcohol services is adapting to the whole person, not just the alcohol part of the person, the whole person, and looking at co-occurring medical, mental health, and other substance use disorders. Looking at the whole person applies across healthcare and just not looking at the pieces of the person. And the other key issue is identifying opportunities that are less siloed, using the entire medical system as opportunities for dealing with alcohol problems, and also the community. I haven't spent much time talking about the other parts of community where opportunities exist for dealing with alcohol problems, the criminal justice system, housing, and the workforce. And finally, dealing with services across the full continuum of care. We talked about prevention, identification, retreatment, and recovery throughout, but this is the full continuum, and it is absolutely key. And I will just conclude with our final slide. I mentioned at the beginning that the very famous Institute of Medicine study was called Crossing the Quality Chasm. So where are we? Are we about to be in that old Mustang crossing the quality chasm? And I would argue that the system has changed a lot, but we do have the basic tools of health services research to get us to the other side and help close the treatment gap and get services to people. So with that, I would like to say thank you. There's no better time to act, and using the tools of health services research to make a difference.
And thank you for me
Dr.
as well.
Reif and I thank you very much for your attention.